هو مش ظاهر بس. اوكي. طيب. هو اني واحد اللي يخليني بعد كده اعرف اشغل فيديوهات، يعني ليزر بوينتر ولا اني واحد؟ خلينا ماشي. هو الماوس ما بيبانش. طيب بسم الله الرحمن الرحيم. احنا will be talking about the transvenous approach for dural fistula. We'll be talking about some tips and tricks related specifically to the usage of coils with onyx. We make a pack with coils and then we inject onyx inside. So when we talk about transvenous approach for the dural fistula, we have to start by the indirect carotid cavernous fistula, because we know that the indirect type carotid cavernous fistula is one of the most common types of dural fistula that are treated by transvenous approach. لأن هو الترانس-arterial approach في indirect type carotid cavernous fistula is not recommended. The transvenous is a standard of care for such cases. فاحنا ال standard technique for transvenous approach in مش ماشي. The standard approach for managing indirect type carotid cavernous fistula by transvenous approach is to go through the inferior petrosal sinus, as we know. هنا احنا we can see the indirect type carotid cavernous fistula on the right side supplied by branches from the internal and the external carotid artery, and also from the contralateral side we can see the supply. And here we have the cavernous sinus on the right side, and we can see clearly the inferior petrosal sinus. On the lateral view we can see the cavernous sinus, and here we have the inferior petrosal sinus, cavernous sinus supplied by branches from the external carotid as well, and the inferior petrosal sinus. This is one of the straightforward techniques. We go up maybe transjugular and maybe transfemoral, and then we go by the guiding catheter or maybe even burn catheter. We put the tip of the catheter into the inferior petrosal sinus, and then we advance our microcatheter until we reach the cavernous sinus, where we deploy some coils. Here we have the burn catheter, and through the burn catheter we have a microcatheter. We use a microcatheter that we can use for deployment of coils, like an echelon or headway microcatheter, and it should be also a DIMSO compatible microcatheter to use also for injecting onyx. So we use the microcatheter first to make a pack of coils, and then using the same microcatheter we start to inject onyx to fill the rest of the cavernous sinus, and this is after embolization and occlusion of the fistula complete. When we have the inferior petrosal sinus axis is not patent, so we can try to recanalize the inferior petrosal sinus like what we have in this case. We can see carotid cavernous fistula indirect type, but superior ophthalmic vein is not that prominent, so we cannot go by superior ophthalmic or facial vein, and the inferior petrosal sinus also is not patent, so we have to recanalize the inferior petrosal sinus. We can see here, this is a point of fistula, the cavernous sinus, and we don't have any direct access, so we will try to recanalize the inferior petrosal sinus as we mentioned. We go up with the burn catheter, and we know the direction of the inferior petrosal sinus, so we direct our burn catheter to the location of the junction between the inferior petrosal and the sigmoid sinus, and then we advance our 0.35 microwire trying to recanalize the inferior petrosal sinus. And when we recanalize the inferior petrosal sinus, we do a negative roadmap to have the track clear, and then through the same track we advance our microcatheter to reach the cavernous sinus, and then we can put coils or we can inject few drops of onyx, and this is after occlusion of the fistula is totally occluded. So recanalizing the inferior petrosal sinus is one also of the transvenous approaches that we do in case of indirect type carotid cavernous fistula. This is another case where we have also an indirect type carotid cavernous fistula supplied by branches from both sides, but here we can see that the superior ophthalmic vein is connected to a good caliber facial vein that we can catheterize by direct puncture under ultrasound guidance. So we do ultrasound guidance, we puncture the facial vein, we put our cannula and we connect the cannula to a Y connector, and then through the cannula we can advance directly a microcatheter reaching through the facial vein to the superior ophthalmic vein, and then backwards facial, superior ophthalmic, and then backwards reaching the cavernous sinus, where we deploy coils, and through the same microcatheter that should be a DIMSO compatible microcatheter we can start to inject our onyx, And here we have the pack of coils and onyx, and this is after complete occlusion of the fistula. In some cases, it's difficult to catheterize, to puncture directly the fascial vein when the caliber of the fascial vein is not that big. So we can go by another approach where we have to do surgical exposure of the superior ophthalmic vein by an ophthalmologist. We have several cases like that where we expose the superior ophthalmic vein and then we did direct puncture of the superior ophthalmic vein. We put a cannula, and through the cannula we advance our microcaster also through the superior ophthalmic vein, reaching the cavernous sinus where we put coils, and then we inject onyx, and the fistula is totally occluded, as we can see here on the right side. So what about other types of dural fistula, not the indirect type carotid cavernous fistula? How we do it using coils and onyx in the superior sagittal sinus, in the transverse sinus, in the torcular. So actually it should be type 2. We don't occlude type 1 dural fistula by occluding the sinus completely. It should be type 2, and we have to make sure that the sinus is not functioning. Because if we have a functioning sinus, you cannot occlude the sinus, otherwise you will have a venous infarction. So we have to make sure that the sinus is functioning. How we do this? We do this by going to the very delayed venous phase of the angiogram, and we make sure that the normal veins of the brain don't go into this sinus, and the sinus is occupied by the high flow from the fistula. If we have an unfunctioning sinus, we have a theoretical question. Is it better to keep the patency of the sinus? Maybe if we occlude the fistula and we keep the patency of the sinus will regain its function later on, or it doesn't make any difference to occlude the sinus as long as it's not functioning. This is a theoretical question, or let's say a debatable question. But actually, to be able to keep the patency of the sinus if it's not functioning, or even if it's functioning, we have to inflate the large and wide bore balloon, the venous balloon, which is a Copernic balloon that is not available in Egypt. So we have other options. Maybe we can inflate PTA peripheral balloons. They don't have the same compliance, and they don't have the same safety like the Copernic balloon, because they are angioplasty balloons. But if we are sure that the sinus is not functioning, we can go and we can occlude the sinus safely, because we know that the sinus is not functioning, so we will not have a venous infarction. How we do this technically? We go by an 8 French guiding catheter through the venous side, and then usually we use 2 microcasters and sometimes even 3 microcasters through the 8 French guiding catheter. Like in this case, for example, here we had a child, a male patient, 1.5 years, who presented by a dural fistula causing headache and intractable convulsions. And this is the angiogram of the patient. He had a dural fistula. Oh, الفيديو مش شغال. Okay. Opening into the torcular hierophyllae. And this is the site of the fistula. And we go to the very delayed venous phase, and we make sure that the sinus is not functioning from the internal carotid on the right side, from the internal carotid on the left side, and also from the vertebrobasilar system, just to make sure that the torcular is not used to drain the normal venous drainage of the brain. I think that we don't have any option here to keep the patency of the sinus using balloons. This is the torcular itself, so we don't have a balloon that can conform to the shape of this torcular. So we have just to make sure that the torcular is not functioning, and then we go and we occlude the fistula. This is our microcaster. Here we used, I think it was in this case only 1 microcaster, cannot remember, maybe 1 microcaster through which we deployed coils, and then, yes, 1 microcaster through which we deployed coils, and then we injected onyx, and this is after occlusion of the fistula, and the patient is fine clinically. We followed the patient even several months after, and he was fine clinically. This is another case of dural fistula to the right sigmoid sinus, and we can see that the sigmoid sinus is not continuing to the internal jugular. There are many also options. We can try to recanalize the junction between the sigmoid and transverse and internal jugular and put a stent, and maybe a stent will help to decrease the fistula, or we can go and we can occlude the sinus completely, as long as we are sure that it's not a functioning sinus. So here it's easier to go from the contralateral side. This is a sinus also. We can see the site of the fistula. So we are going to occlude all this part of the sinus. We have to make sure that we are away from, it's very important to study the hemodynamics of the flow of the veins in the delayed phase to make sure where the vein of Labé, for example, will be going, and the vein of Labé will be continuing to drain into the sinus, maybe to the contralateral side. So we have to avoid having onyx refluxing till the point of the vein of Labé. This is a site of the fistula, so we are going to occlude this part of the sigmoid sinus. We went transarterial and transvenous, and we went up with our guiding caster, and through the guiding caster we advanced 2 microcasters. We will start to put coils from the first one, and then we will inject onyx from the other one. We tend to put the 2 microcasters in 2 different locations. We don't put them at the same location. So at the beginning we started by putting them here, and from one of the microcasters we started to put coils, and the other microcaster we leave it at the most distal point. And then with the microcasters that we are using to deploy coils, we will retrieve it a little bit till this point. So at the end of deploying the coils, we'll have 2 microcasters, one distally located and the other one more proximally located. So we have 2 different locations to inject onyx, and it's very useful because sometimes when we start to inject onyx from one microcaster, it can diffuse to other places that you don't want to. So you have another backup microcaster to inject onyx from. And this is at the end where we deployed coils and we injected onyx, and we occluded the fistula completely, and the tinnitus that the patient had disappeared completely. Another patient having also dural fistula. It's a huge dural fistula draining to the transverse sinus and maybe reaching the torcula and the other maybe transverse sinus. Supplied also by multiple branches from both sides and from the vertebro-basilar system. This is a supply coming from the external carotid, and we saw also the supply coming from the contralateral side. So the whole part of the torcula and the proximal parts of the transverse sinus on both sides are involved in the fistula. And we made sure in the very delayed venous phase, we have to check the venous phase of the internal carotid and the vertebro-basilar system. We make sure that the sinus is not functioning, neither the torcula nor the proximal parts of the transverse sinus, as we can see here. So we have venous rerouting. Okay? And this is the vertebro-basilar system, so it's a huge fistula. I don't think that we have any option other than occluding the whole fistulized pouches of the sinuses. So we go by 2 microcasters. We put one at the very distal location. The other one we will use to deploy coils, and then we will get the second one in a more proximal location after deploying the coils. So we start by deploying coils here, okay? More coils and more coils. And then now we have 1 microcaster maybe here, and the other microcaster in the most distal location. And then we start to inject onyx by the most distally located one. And when we have the onyx diffusing a little bit distal more than we want, we stop injecting from it, and then we start to inject from the other one. We can alternate injecting from both microcasters, and sometimes we inject from both together. So here we started to inject onyx. It started to diffuse a little bit distal more than we want, so we stopped injection from it, and then we start to inject from the other one, and then we alternate to the first one. And this is at the end of the procedure where we occluded the whole fistulized pouches of the sinus. But we have to pay attention not to stop injection from any of the microcasters more than 2 minutes to avoid its occlusion. And here the 2 microcasters during our injection. It can be done by the same operator, and it will be easier if it's done by 2 operators, each one taking care of one of the microcasters and alternating the injection from one to the other according to the diffusion of the onyx during the procedure. And this is at the end of the procedure where we can see the fistula is totally occluded. We have only the arteries that are still a little bit prominent, but there is no more fistula. Those arteries in the follow-up will regress in size. And the patient is fine clinically. So I know that occluding those sinuses with the torcula and transverse sinus, and maybe the vein of Galen, as we will see in the last case, is maybe a little bit, I don't know, maybe it's a little bit, we feel that it's a little bit risky, but actually we have a famous status by Jacques Moret that it's an occluded sinus is better than a fistulized sinus. If you have a fistulized sinus, the pressure will be much, much higher compared to an occluded sinus. Like what we have in the carotid cavernous fistula, for example. You have a carotid cavernous fistula, you have the patient symptomatic with orbital manifestation, and then you go and you occlude the sinus, and the patient will improve clinically. أنا فاضل لي إيه يعني 30 ثانية. And this is the last case that we will present, a case of dural fistula to the vein of Galen. Okay. A trial to embolize this fistula by transarterial approach before was not successful. We made sure that the vein of Galen is not functioning. It's a very big one. The patient had intractable headache and epilepsy, and reduction is in cognitive functions. طبعا to study the hemodynamics of all the dural fistula يعني will take a very long time, فأنا بس إيه بعرضهم بس كده. And this is the fistula supplied by both sides and the vertebrobasilar system as well. So we went by our microcaster and we tried to fix coils within the vein of Galen. It was not easy. The flow was very high. So it was very difficult to stabilize coils. We went by another microcaster until at the end we succeeded to stabilize first coil in a pouch of the vein of Galen, and then we started to try also to stabilize the second coil through the first microcaster. So we have two microcasters, one here and the other one stabilize the second coil here. It was not easy also to stabilize this coil, so we started to inject onyx from here, and then when we had a cast of onyx here, we started to deploy coils from the first microcaster, and the cast of onyx that was present here allowed us to stabilize the coils from the first one, so onyx and then coils from the first microcasters, and then now we can continue to inject onyx alternating from both microcasters, and this is deployment of the coil from the first microcaster. It was not possible at the beginning, but when we have here some coils and onyx, it stops the coils from jumping with the flow. And then we continue to inject onyx, and this is after occlusion of the fistula. We can see the fistula is totally occluded and the patient is clinically fine. Thank you.